The French healthcare system is one of universal healthcare largely financed by government national health insurance. In its 2000 assessment of world healthcare systems, the World Health Organization found that France provided the close to best overall healthcare in the world. In 2011, France spent 11.6% of GDP on healthcare, or $4,086 per capita, a figure much higher than the average spent by countries in Europe but less than in the US. Approximately 77% of health expenditures are covered by government-funded agencies. Most general physicians are in private practice but draw their income from the public insurance funds. These funds, unlike their German counterparts, have never gained self-management responsibility. Instead, the government has taken responsibility for the financial and operational management of health insurance. The French government generally refunds patients 70% of most healthcare costs, and 100% in case of costly or long-term ailments. Supplemental coverage may be bought from private insurers, most of them non-profit, mutual insurers. Until 2000, coverage was restricted to those who contributed to Social Security. Excluding some poor segments of the population, the government of Lionel Jospin put into place universal health coverage and extended the coverage to all those legally resident in France. Only about 3.7% of hospital treatment costs are reimbursed through private insurance, but a much higher share of the cost of spectacles and prostheses, drugs and dental care. There are public hospitals, non-profit independent hospitals, as well as private for-profit hospitals. Average life expectancy in France at birth is 81 years. History. The current system has undergone several changes since its foundation in 1945, though the basis of the system remains state-planned and operated. Jean de Courvestouet, a health economist, believes that French medicine is of great quality and is the only credible alternative to the Americanization of world medicine. According to Courvestouet, France's surgeons, clinicians, psychiatrists, and its emergency care system are an example for the world. However, despite this, Courvestouet criticizes the fact that hospitals must comply with 43 bodies of regulation and the nitpicking bureaucracy that can be found in the system. Courvestouet believes that the state intervenes too much in regulating the daily functions of French hospitals. Furthermore, Japan, Sweden, and the Netherlands have healthcare systems with comparable performance to that of France's, yet spend no more than 8% of their GDP. According to various experts, the battered state of the French social security system's finances is causing the growth of France's healthcare expenses. To control expenses, these experts recommend a reorganization of access to healthcare providers, revisions to pertinent laws, a repossession by CNAMTS of the continued development of medicines, and the democratization of budgetary arbitration to counter pressure from the pharmaceutical industry. Healthcare system. The entire population must pay compulsory health insurance. There are three main funds, the largest of which covers 84% of the population and the other two a further 12%. A premium is deducted from all employees' pay automatically. The 2001 Social Security Funding Act set the rates for health insurance covering the statutory health care plan at 5.25% on earned income, capital and winnings from gambling and at 3.95% on benefits. After paying the doctor's or dentist's fee, a proportion is reimbursed. This is around 75 to 80%, but can be as much as 85%. The balance is effectively a co-payment paid by the patient, but it can also be recovered if the patient pays a regular premium to a voluntary health insurance scheme. Nationally, about half of such co-payments are paid from VHI insurance and half out of pocket. Under recent rules, general practitioners are expected to act as gatekeepers, who refer patients to a specialist or a hospital when necessary. However, the system offers free choice of the reference doctor, which is not restricted to only general practitioner and may still be a specialist or a doctor in a public or private hospital. The goal is to limit the number of consultations for the same illness. The incentive is financial in that expenses are reimbursed at much lower rates for patients who go directly to another doctor. Vital emergencies are still exempt from requiring the advice from the reference doctor, which will be informed later, as costs are borne by the patient and then reimbursed. Patients have freedom of choice of where to receive healthcare services. Around 65% of hospital beds in France are provided by public hospitals, around 15% by private non-profit organizations, and 20% by for-profit companies. Minister of Health and Solidarity is a cabinet position in the government of France. The healthcare portfolio oversees the public services and the health insurance part of Social Security, as ministerial departments are not fixed and depend on the Prime Minister's choice. The minister sometimes has other portfolios among work, pensions, family, the elderly, handicapped people, and women's rights. In that case, they are assisted by junior ministers who focus on specific parts of the portfolio. Fees and reimbursements. Médecin généraliste. The médecin généraliste is responsible for patient long-term care. This implies prevention, education, care of diseases and traumas that do not require a specialist. They also follow severe diseases day-to-day. They survey epidemics, fulfill a legal role, and a role in emergency care. They often go to a patient's home if the patient cannot come to the consulting room, and they must also perform night and weekend duty. Health insurance. Because the model of finance in the French healthcare system is based on a social insurance model, contributions to the program are based on income. Prior to reform of the system in 1998, contributions were 12.8% of gross earnings levied on the employer and 6.8% levied directly on the employee. The 1998 reforms extended the system so that the more wealthy with capital income also had to contribute. Since then, the 6.8% figure has dropped to 0.75% of earned income. In its place, a wider levy based on total income has been introduced. Gambling taxes are now redirected towards healthcare, and recipients of social benefits also must contribute. Because the insurance is compulsory, the system is effectively financed by general taxation rather than traditional insurance. The founders of the French social security system were largely inspired by the Beveridge Report in the United Kingdom and aimed to create a single system guaranteeing uniform rights for all. However, there was much opposition from certain socio-professional groups who already benefited from the previous insurance coverage that had more favorable terms. These people were allowed to keep their own systems. Today, 95% of the population are covered by three main schemes: one for commerce and industry workers and their families, another for agricultural workers, and lastly the National Insurance Fund for self-employed non-agricultural workers. All working people are required to pay a portion of their income into a health insurance fund, which mutualizes the risk of illness and which reimburses medical expenses at varying rates. Children and spouses of insured individuals are eligible for benefits, as well. Each fund is free to manage its own budget and reimburse medical expenses at the rate it saw fit. The government has two responsibilities in this system. The first is a government responsibility that fixes the rate at which medical expenses should be negotiated, and it does this in two ways. The Ministry of Health directly negotiates prices of medicine with the manufacturers, based on the average price of sale observed in neighboring countries. A board of doctors and experts decides if the medicine provides a valuable enough medical benefit to be reimbursed. In parallel, the government fixes the reimbursement rate for medical services. Doctors choose to be in Sector 1 and adhere to the negotiated fees. To Sector 2 and be allowed to charge higher fees within reason, or Sector 3 and have no fee limits. The Social Security system will only reimburse at the preset rate. These tariffs are set annually through negotiation with doctors' representative organizations. The second government responsibility is oversight of health insurance funds, to ensure that they are correctly managing the sums they receive, and to ensure oversight of the public hospital network. Today, this system is more or less intact. All citizens and legal foreign residents of France are covered by one of these mandatory programs, which continue to be funded by worker participation. However, since 1945, a number of major changes have been introduced. Firstly, the different healthcare funds now all reimburse at the same rate. Secondly, since 2000, the government now provides health care to those who are not covered by a mandatory regime. This regime, unlike the worker-financed ones, is financed via general taxation and reimburses at a higher rate than the profession-based system for those who cannot afford to make up the difference. Finally, to counter the rise in healthcare costs, the government has installed two plans, which require most people to declare a referring doctor in order to be fully reimbursed for specialist visits, and which installed a mandatory co-payment of €1 for a doctor visit, 50 cents for each prescribed medicine, and a fee of €16 minus 18 per day for hospital stays and for expensive procedures. Such declaration is not required for children below 16 years old, for foreigners without residence in France, or those benefiting from a healthcare system of French overseas territories, and for those people that benefit from the minimum medical assistance. An important element of the French insurance system is solidarity. The more ill a person becomes, the less they pay. This means that for people with serious or chronic illnesses, the insurance system reimburses them 100% of expenses and waives their co-payment charges. Finally, for fees that the mandatory system does not cover, there is a large range of private complementary insurance plans available. The market for these programs is very competitive. Such insurance is often subsidized by the employer, which means that premiums are usually modest. 85% of French people benefit from complementary private health insurance. Quality A government body, ANAES. Agence Nationale d'Accréditation et d'Évaluation en Santé was responsible for issuing recommendations and practice guidelines. There are recommendations on clinical practice, relating to the diagnosis, treatment and supervision of certain conditions, and in some cases, to the evaluation of reimbursement arrangements. ANAES also published practice guidelines, which are recommendations on good practice that doctors are required to follow according to the terms of agreements signed between the professional representatives and the health insurance funds. There are also recommendations regarding drug prescriptions, and to a lesser extent, the prescription or provision of medical examination. By law, doctors must maintain their professional knowledge with ongoing professional education. ANAES was combined with other commissions in the High Authority of Health on 13 August 2004. Spending. The French healthcare system was named by the World Health Organization as the best performing system in the world in terms of availability and organization of healthcare providers. It is a universal healthcare system. It features a mix of public and private services, relatively high expenditure, high patient success rates and low mortality rates, and high consumer satisfaction. It aims at to combine low cost with flexibility of patient choice as well as doctors' autonomy. While 99.9% of the French population is covered, the rising cost of the system has been a source of concern, as has the lack of emergency service in some areas. In 2004, the system underwent a number of reforms, including introduction of the Carte Vitale smart card system, improved treatment of patients with rare diseases, and efforts aimed at reducing medical fraud. While private medical care exists in France, the 75% of doctors who are in the national program provide care free to the patient, with costs being reimbursed from government funds. Like most countries, France faces problems of rising costs of prescription medication, increasing unemployment, and a large aging population. Expenses related to the healthcare system in France represented 10.5% of the country's GDP and 15.4% of its public expenditures. In 2004, 78.4% of these expenses were paid for by the state. In a sample of 13 developed countries, France was first in its population-weighted usage of medication in 14 classes in both 2009 and 2013. The drugs studied were selected on the basis that the conditions treated had high incidence, prevalence and/or mortality, caused significant long-term morbidity, and incurred high levels of expenditure, and significant developments in prevention or treatment had been made in the last 10 years. The study noted considerable difficulties in cross-border comparison of medication use. Hospitals. About 62% of French hospital capacity is met by publicly owned and managed hospitals. The remaining capacity is split evenly between non-profit sector hospitals and by for-profit institutions. Public health. France, as all EU countries, is under an EU directive to reduce sewage discharge to sensitive areas. In 2006, France was only 40% in compliance, one of the lowest achieving countries in the EU with regard to this wastewater treatment standard. Healthcare issues in France. Obesity in France. Even though French are among the thinner Europeans, obesity in France has been increasingly cited as a major health issue in recent years. It is now considered a political issue, whereas just a few years prior it would only have been an issue reported on television talk shows or in women's magazines. There is a myth about French people not getting overweight or obese. However, France is only ranked as the 128th fattest country in the world, one of the lowest rank among developed countries, and French food has long been studied for its healthy diet. Doctors. While French doctors only earn about 60% of what American doctors make, their expenses are reduced because they pay no tuition for medical school, and malpractice insurance is less costly compared with the United States. Public perception. Historian Danielle Horan claims that while many in the U.S. deride the French system as socialized medicine, the French do not consider their mixed public and private system socialized, and the population tends to look down upon British and Canadian-style socialized medicine.